Hello, my name is Dr. Olachi Mezu-Ndubuisi. I am an associate professor of pediatrics and ophthalmology at the University of Rochester, New York. The title of my talk is Oxygen Saturation Goals in Retinopathy of Prematurity, a Moving Target. Oxygen saturation goals have really become sort of a moving target in the clinical care of premature infants as clinicians struggle to determine the optimal goals with increasing concerns of rising bronchopulmonary dysplasia and retinopathy of prematurity ROP incidence as more infants are now being born at lower gestational ages. So, I would like to discuss how we got here and how to find a safe path forwards. I have nothing to disclose. The objectives today are to first review the role and effect of oxygen in biological tissues, as well as our current oxygen saturation guidelines here and the need for a practice change. Next, we will highlight the historical evolution of ROP as well as its developmental pathogenesis. Finally, we will critically review the evidence-based studies on oxygen saturation goals, and I will propose changes to our current oxygen saturation guidelines to the group for discussion. Well, a talk about oxygen saturation has to begin with oxygen. Oxygen is a ubiquitous and abundant element. Whether it is a friend or foe remains an enigma, as I like to stress that oxygen is a drug. It is vital to the body and can also be a toxin to the body. All biological processes, including respiration, cell signaling, and the breakdown of food macromolecules for energy, need ATP to function. After glycolysis and the Krebs cycle, oxidative phosphorylation happens in the mitochondria to produce ATP. Oxygen is the final electron acceptor in the electron transport chain. During oxidative phosphorylation, the electrons stored in activated carriers like NADH are transferred through the three enzyme complexes, and the energy release is used to pump protons into the inner mitochondria. The four electrons donated by cytochrome C, part of the last enzyme complex in the chain, are combined with four protons and oxygen to form two molecules of water, and NAD is oxidized in the process. Oxygen has an atomic number of 8, so its outer shell has 6 electrons and the maximum is 8, so it is very highly reactive and can easily pick up any electron to form superoxide radical and other free radicals. Cytochrome C oxidase has a Him unit which sequestered oxygen, preventing the superoxide free radical from picking up more electrons. So you can see that an excess supply of oxygen can easily overwhelm the system, causing free radical damage to the nearby DNA, protein, and lipid membranes. Hyperoxia causes oxygen toxicity, which gives rise to multi-organ dysfunction, leading to retinopathy of prematurity, bronchopulmonary dysplasia (BPD), periventricular leukomalacia, cerebral palsy, acute kidney injury, and other conditions. On the other hand, hypoxia can contribute to increased risk of mortality, so we really still do not know how much oxygen is too much. We are said to have had 3 ROP epidemics. The first epidemic came from excess unrestricted oxygen use in the 1940s. Then, the increased birth of extremely preterm infants in the early 2000s caused the second ROP epidemic. And in the past decade, the third epidemic is seen globally in the low and middle income countries due to inadequate resources to match the increased need for ROP screening and treatment with increased survival of more preterm infants. Oxygen was discovered to be vital for life by Polish scientists in 1604. Many infants survived that would not have previously survived. In 1940s, 70% oxygen was noted to improve apneas, but by 1951, Campbell in Australia suggested that unrestricted use of oxygen was associated with an increased risk of retrolental fibroplasia that presented as a fibroscar in the retina. In the clinical practice of restricted oxygen use to 40% that was adopted then, some studies after that started to report an increase in mortality in the low birth weight infants. In the 1970s, ROP was found to be strongly associated with supplemental oxygen exposure. In 1980s, continuous oxygen monitoring and pulse oximetry were discovered to better monitor oxygen exposure in preterm infants. The cryo-RUP study in the 1980s showed that cryotherapy could be used to prevent retinal detachment and subsequent blindness in ROP. In the 1990s, the EAT-RUT study, the largest multi-center study on ROP till date, that screened nearly 10,000 infants, showed the benefit of early treatment of severe ROP, and laser photocoagulation soon became the standard of care over cryotherapy. Then came the STOP-RUT study, the first randomized controlled trial of oxygen saturation, and it tried to use supplemental oxygen to try to prevent progression to proliferative ROP. Unfortunately, the results did not approach statistical significance except in the subgroup analysis. In the mid-2000s, with improved clinical practice, Dr. Joby and group in Cincinnati described the new BPD in very low birth weight babies that had simplified alveolar architecture and altered vasculature compared to the old BPD in bigger babies with severe lung inflammation and fibrosis. By 2011, the BEAT-RUP study using bevacizumab, an anti-VEGF monoclonal antibody, was published and soon became accepted as standard of care in addition to laser therapy. In 2007, the guidelines for perinatal care recommended an oxygen saturation range of 85% to 95%, and most NICUs adopted this. From 2012, several neonatal trials and meta-analysis started to show that low saturations reduced the incidence of ROP but led to an increase in mortality, while some studies did not show these concerns. Well, the conflicting results could be in part due to a study design that did not account for the biphasic pathogenesis of ROP. And these trials were mainly geared towards the study of BPD as a primary outcome and not ROP. So, indeed, oxygen use and oxygen saturation goals have been a moving target. So, the optimal oxygen saturation target to prevent ROP and avoid oxygen toxicity from too high oxygen without a risk of mortality from too low oxygen is still unknown. Based on several randomized controlled trials and meta-analysis that showed increased mortality in low oxygen saturation groups, the American Academy of Pediatrics Committee on Fetus and Newborn recommends SpO2 oxygen saturation goals of 90% to 95% in extremely low birth weight infants as safer than 85 to 89%. However, in recent years, centers in the United States and Australia have seen the ROP incidence increase, not only with increased survival of extremely preterm infants, but also due to these recommendations with adopting higher oxygen saturation goals. In the next 6 slides or so, I will be presenting a brief look at the ROP data in our NICU. The current oxygen saturation target range is 90 to 95% in NICU with alarm limits set at 84 to 96%. I looked at 3 years of data from 2020 to 2022, which is about 513 patients. I first reviewed the demographics per year. Each year was matched equally for patient demographics such as birth rate, gestational age, and length of stay. Next, I looked at demographics by ROP diagnosis and found that the patients diagnosed with any ROP were significantly smaller, with a mean of 25 weeks compared to 29 weeks for patients without ROP. This is no surprise here, as the smallest gestational age are at most risk for ROP due to developmental immaturity. In addition, the patients with ROP diagnosis of any stage were smaller in birth rate and had longer length of stays than those without ROP diagnosis. Reviewing the demographics by gestational age, I grouped the babies into 3 gestational age cohorts: 22 to 26 weeks, 27 to 31 weeks, and 32 to 35 weeks to approximately match their ROP risks. Both birth rate and length of stay were significantly different between the cohorts. The smallest gestational age cohort, the 22 to 26 weeks, as expected, had babies of the lowest gestational age with a mean of 735 grams and the longest length of stay at a mean of 96 days, compared to the 68 and 35 days in the 27 to 31 weeks and the 32 to 35 weeks cohort, respectively. Then, I compared gestational age, corrected gestational age at first ROP exam, and the corrected gestational age at which the babies received either anti-VEGF or laser therapy by years. Babies appear to have received anti-VEGF treatment or laser therapy earlier in 2022 compared to 2020, and this likely is a reflection of having babies of much lower gestational ages like 22 to 24 weeks surviving in 2022. The range of duration in weeks between the first eye exam and needing ROP treatment of either laser or anti-VEGF therapy was anywhere from 3 to 4 weeks to 11 weeks. The means are presented here. This underscores the importance of not missing those eye exams, even if immature at the first eye exam, and also continuing to be cautious about the oxygen saturations throughout use of supplemental oxygen and avoiding episodes of fluctuating SATs or hypoxic episodes. Any ROP diagnosis was highest in 2022 compared to other years. The rates of any ROP, severe ROP, and anti-VEGF therapy was highest in the 22 to 26 week cohort than other cohorts. The incidence of BPD, IVH, pulmonary hypertension, patent ductus arteriosus PDA, and treatment for PDA was higher in babies with ROP compared to babies without ROP. However, there was no difference between these outcomes over the 3 years. This brings us to the question of why should we modify our oxygen saturation goals at University of Rochester? Well, stationary oxygen saturation goals of either keeping low or high oxygen saturation targets throughout the stay of the infant do not mimic ROP pathogenesis or physiology. A transition of oxygen saturation goals after 4 weeks of life would better approximate the biphasic pathogenesis of ROP and mimic the physiologic changes in vascular oxygen tension in a developing newborn infant. We would also want to minimize the risk of oxygen toxicity encountered with high oxygen saturations above 90% shortly after birth, which lead to phase 1 ROP or vasoobliteration. It has been shown that a larger avascular peripheral retinal area worsened retinal neovascularization in phase 2 ROP. We also want to avoid keeping too low oxygen saturation range in the 80s throughout the NICU stay of the infant because it worsens the ongoing retinal hypoxia in phase 2 ROP and can lead to higher risk of mortality, as shown in several studies that we will review shortly. Although the ideal oxygen saturation target ranges that would decrease ROP and not increase mortality in extremely premature infants is unknown, a biphasic approach would hopefully improve long-term visual and neurodevelopmental outcomes in the infant. So to support this theory, one needs to look at retinal vascular development in the preterm infant and ROP pathogenesis. Retinal vascularization starts in utero at about 16 weeks gestation from the optic nerve outwards. The nasal retina is vascularized at 36 weeks and the temporal retina at 40 weeks. Prematurity disrupts vessel growth, creating an avascular retinal periphery. The differences in the in utero and ex utero environment drives the preterm infant's adaptations to extrauterine life. In utero, there is low oxygen tension, creating a physiologic hypoxia with a PaO2 of about 20 to 35 millimeters of mercury, which upregulates vascular endothelial growth factor VEGF and stimulates blood vessel development not only in the retina, but in the lungs, the brain, kidneys, and all fetal organs. While following birth, in the canalicular stage of lung development, preterm babies are now exposed to a sudden increase in oxygen tension with a PaO2 in ambient air of about 150 millimeters of mercury, and after correcting for water vapor, the lungs sees about 100 millimeters of mercury. Well, hyperoxia downregulates VEGF, and this causes arrested vascularization in the retina, as well as the lungs and other organs. This starts the first phase of ROP, or vasoobliteration. Now, 4 to 6 weeks later, the infant matures and organs now continue to develop with the very highly metabolically active retina that has a complex network of neurons and glial cells. And we know the retina is the most metabolically active tissue in the brain. Well, it now does not have enough blood vessels in the retina to nourish the retinal neurons and glial cells and photoreceptors. Well, this causes hypoxia to start in the retina, leading to excess VEGF production, and this causes the retinal vessels to proliferate abnormally. The new vessels that are formed are now fragile, and they start to bleed and can lead to phase 2 ROP, or vasoproliferation, or pathologic neovascularization. So oxygen saturation goals need to match the change in physiology of the infant. In utero, the oxygen saturation levels in umbilical vein are anywhere from 50 to 70%. This is why at birth we normally now allow physiologic hypoxemia, and we should, because we should let the oxygen saturations go anywhere from about 86 to 90% or thereabouts to promote a smooth transition of vascularization in the retina and lungs and continued normal levels of VEGF expression. Then, from 4 weeks, to match the increased tissue oxygen demands and to prevent excess hypoxia, we should allow what I call permissive normorexia to enable goal saturations of about 92 to 96%. We should avoid enabling 100% SADs when using supplemental oxygen to minimize the risk of oxygen toxicity and cellular injury. The International Classification for ROP describes the stages and zones. Stages refer to the vessel appearance at the vascular-avascular interface. Stage 0, of course, is no ROP, where the vessels look immature, and in stage 1, there is a demarcation line that forms at that vascular-avascular interface. You no longer see a fine blending of those vessels into the periphery. You can see clearly where the vessels stop to grow and the rest of the avascular retina. In stage 2, a 2 to 3D intraretinal ridge forms at the vascular-avascular interface. If you ran your fingers over it hypothetically, you could almost feel like a little lump or bump at that interface. It's no longer flat because of proliferation of vessels. In stage 3 ROP, this defines the development of intraretinal neovascularization above and around that fibrobascular ridge. Stage 4 is partial retinal detachment from the underlying pigment epithelium of the choroid. And stage 5 is total retinal detachment or blindness, which we do not want. Zones refer to the area of vascularization relative to the optic disc. Zone 1 is a concentric circle centered around the optic disc and 2 disc diameters temporally to include the macula, which is the point of sharpest vision and color vision. Zone 2 is a concentric ring around Zone 1, extending from Zone 1 to the nasal peripheral retina. Zone 3 is the remaining crescent-shaped area on the temporal retina. The extent of ROP is defined by clock hours of eye circumference that is affected. So 9 clock hours would be 270 degrees of retinal area. So when do we have the first eye exam? Well, the timing of the first ROP exam is about 31 weeks postmenstrual age or 4 to 6 weeks after birth, whichever comes later. ROP correlates much better with postmenstrual age, which is your gestational age plus chronological age, than your postnatal age. So who gets screened? The ROP screening guidelines were revised in 2018 by the AAP section on ophthalmology. The committee recommended screening of all infants with birth weight less than 1,500 grams or gestational age of 30 weeks or less. They also recommended screening of selected infants 1,500 to 2,000 grams at birth or gestational age more than 30 weeks who were clinically unstable or at risk for ROP per the neonatologist. This would include infants on inotropic support for low blood pressures, those who receive supplemental oxygen for more than a couple days, or who got oxygen without any monitoring of their saturations, which sort of is not typically the case these days. The early treatment of retinopathy of prematurity, EATROP randomized a controlled trial, confirmed the efficacy of early treatment of high-risk pre-threshold ROP. They actually replaced the term pre-threshold ROP and threshold ROP with type 1 ROP and type 2 ROP respectively. Type 1 ROP is your aggressive treatment required ROP, and type 2 is a more indolent, less aggressive type. Peripheral retinal ablation should be considered for any eye with a type 1 ROP or the new threshold disease, which is defined as Zone 1, any stage ROP with plus disease, Zone 1 Stage 3 ROP with or without plus disease, and Zone 2 Stage 2 or 3 ROP with plus disease. Serial examinations are recommended for any eye with type 2 ROP, which is the former pre-threshold disease, and this would be your Stage 3 in Zone 2 or any ROP in Zone 1. So this is a comparison of normal retina and ROP with plus disease in an infant. You can see the normal caliber of arteries and veins in the retina on the left side. In the abnormal retina, one can appreciate the very dilated and tortuous vessels that define plus disease, which is a marker of ROP severity. You can also see bleeding occurring in the periphery of the retina in that image. The standard therapy for type 1 ROP is laser photocoagulation. This photo shows stage 3 zone 2 ROP, and adjacent to it is the same retina post-laser ablative therapy. You can see chororetinal scarring secondary to laser treatment temporarily in the retina. Also note the regression of plus disease and the involution of neovascularization at the boundary between vascular and avascular retina. Type 1 ROP or threshold disease should be treated within 72 hours to minimize the risk of retinal detachment. The duration of follow-up for these infants is until full retinal vascularization is attained, which is zone 3 without previous zone 1 or 2 ROP. Otherwise, they are followed until 45 weeks postmenstrual age and no threshold disease is seen, and threshold again is stage 3 ROP in zone 2 or any ROP in zone 1. Well, laser therapy causes full-thickness burns in the treated retinal periphery, which correlates with peripheral visual deficits. In 2018, the American Academy of Pediatrics added in their guidelines that if anti-VEGF therapy was used, the follow-up should continue till about 65 weeks postmenstrual age at least. Well, this is because the peripheral retina, though it revascularizes following anti-VEGF therapy compared to laser, there is a recurrence or reactivation of proliferative ROP in the treated eye, and this has been seen as late as 70 weeks postmenstrual age. We're now going to discussing the clinical trials for ROP over the years. The STOP-ROP trial compared oxygen saturation targets looking at low sats at 89 to 94% versus high saturation targets of 96 to 99% in a total of 649 patients in 30 centers over 5 years. They randomized these patients to either receive supplemental therapeutic oxygen with high SAT goals to reduce progression to threshold disease and the need for peripheral retinal ablation versus the conventional arm that just maintained lower SATs throughout the stay of the baby in the NICU. Well, supplemental oxygen, they found, did not significantly reduce the number of infants requiring laser surgery. However, a post-hoc subgroup analysis suggested that infants without plus disease had less ROP progression than those with plus disease following supplemental oxygen. So there may be a benefit of catching these babies earlier to prevent ROP progression. Secondary analysis also showed that a higher oxygen saturation group had worsened pneumonia, BPD exacerbations, and had more use of diuretics, about 13% compared to the lower SAT group at 8%. This study was done in England and looked at 1-year outcomes comparing 4 oxygen saturation goals in babies 23 to 27 weeks gestational age. There were lower retinal ablation rates with threshold ROP at 6% in babies with lower saturation targets of 70 to 90% compared to the higher SAT groups that maintained 88 to 98% SATs. The rates of death and cerebral palsy did not differ significantly between these groups. Patients maintaining oxygen saturation of 88 to 98% for the first 8 weeks of life developed severe ROP treated with cryo 4 times as often as babies only given enough oxygen to maintain an oxygen saturation of 70 to 90% at a rate of 27 versus 6% respectively. They also found that ventilatory support before discharge in the 1-year survivors were analyzed and found that the half of the survivors in the low SAT group using the 70 to 90% targets were off vent support by 7 days, while the other half of survivors of the group that received higher target SATs 88 to 98% took 21 days to get off the vent. Next, we're going to look at the support trial, and this is a surfactant, positive pressure, and oxygenation randomized controlled trial. So the support trial was very elegantly done and a complex multi-center study that was done as a part of the the Neonatal Research Network (NRN) of the NICHD, and the study design, however, appeared to be slightly flawed with respect to ROP. Again, it did not have the biphasic transition that should happen in the babies after 46 weeks of life in their targeting their oxygen saturation. So data was collected from infants born at 24 weeks to 27 and 6 weeks gestational age from February 2005 through February 2009. Out of 3,546 babies screened, 2,200 were excluded, and about 1,300 were randomized to either get early CPAP to limit ventilation, which is about maybe 663 of those babies, versus the remaining 650 babies received surfactant after intubation. This table shows that the lower and high saturation groups were equally matched for their baseline characteristics of birth weight, age, sex, race, and surfactant treatment, and this helps eliminate bias. The primary outcome of the support trial was a composite of severe ROP, death before discharge from the hospital, or both. Severe ROP was defined as the presence of threshold retinopathy, need for surgical intervention, or the use of bevacizumab. The composite primary outcome in support did not differ significantly between the lower and the higher oxygen saturation groups. The rate of severe ROP among survivors was 8.6% in the lower sat group versus 17.9% in the higher saturation group. However, death before discharge from the NICU was higher in the lower sat group in 19.9% of infants compared to 16.2% of infants in the higher saturation group, with a relative risk of 1.27 at 18 to 22 months of corrected age. But there was no difference in the composite outcome of death or neurodevelopmental impairment at 18 to 22 months corrected age. There was considerable overlap between the two low and high saturation groups, which you really do not want. However, this graph shows that the actual median oxygen saturation distribution in the two treatment groups has significantly different peaks with a p-value of less than 0.001. They showed in this graph that 80% level of oxygen saturation includes all values at or below 80% in that graph. The Kaplan-Meier estimate of survival showed that there was an increased hazard of death in the lower oxygen saturation group compared with the higher oxygen saturation group. They followed these babies till hospital discharge, transfer, or 1 year of life. The BOOST trials were 3 international randomized controlled trials comparing the effects of low saturation 85 to 89% versus high sat 91 to 95% on disability-free survival at 2 years in infants born less than 28 weeks. 2,448 infants were recruited. There was no difference in all pooled analysis of the 3 trials in the primary outcome of death or neurodevelopmental impairment at 18 to 22 months in either low or high SAT groups. In the post hoc analysis combining 2 of the 3 trials, the primary outcome occurred in 48.1% in the lower SAT target group versus 43% in the higher SAT target group. Halfway through the trials, though, the oximeter calibration algorithm was revised and the recruitment was stopped really early. Once they found that the interim analysis showed increased death at 36 weeks in the lower SAT groups. Those in the lower SAT groups had a reduced rate of ROP 10 versus 13% and an increased rate of NAC at 10 versus 8%. The neonatal oxygenation prospective meta-analysis collaborative study called the NEOPROM was another elegant meta-analysis, and this reviewed 4,900 infants born at less than 28 weeks with low SAT group ranged 85 to 89% versus a high SAT group targeting 91 to 95%. And they randomized these babies within the first 24 hours of life, and they got the studies from 5 randomized controlled trials. Well, the interesting part of this is originally this was planned as the post-ROP study, the pulse oximetry saturation trial for prevention of ROP, and it was an international multi-center single trial, but the participants found it easier to obtain separate funding from their local agencies. The trials that were included were the support trial that was funded by the NIH, the 3 boost trials, which is the benefits of oxygen saturation targeting trial, and these were in Australia, New Zealand, and the UK, and the Canadian oxygen trial, the CUT trial, in Canada. Well, these trials collected data prospectively and all agreed to standardize their parameters like the low and high SATs, ranges, gestation age less than 28 weeks, and birth weight less than 1251 grams, and they committed to submit their data to the NEOPROM Collaborative. So I really was fascinated by how they got it all coordinated, and this was really awesome. This table is a comparison of the outcome variables for each trial, and we will go through each outcome. I just wanted to point out the subtle differences in the way these studies define some outcomes that may or may not have impacted their pooled results. Mortality was defined as 18 to 22 months in the support trial, before discharge in the boost trials, and before 18 months in the CUT trial. But what was unique about the CUT trial was that they achieved a higher rate of compliance, as the study participants were maintained in their targeted oxygen range between 68 to 79% of the time. And we know that most trials really struggle to achieve even 50% compliance with oxygen saturation goals. Severe ROP in the treatment varied as well. The support defined severe ROP as threshold needing eye surgery or bevacizumab, while Boost used the EHROP treatment guidelines, which were laser and cryo, and the COT used everything, stage 4 or 5, cryo, laser, or bevacizumab. This forest plot shows the summary of the meta-analysis of severe ROP in infants in low versus high oxygen saturation targets. The relative risk and 95% confidence intervals are given. Basically, a relative risk exceeding 1 favors a high oxygen saturation. The box in the middle of each horizontal line or the confidence interval represents the point estimate of the effect for a single study. The size of the box is proportional to the weight of the study in relation to the pooled estimates. The solid line on the forest plot is the point of no effect for a relative risk of 1, and the dashed line represents the overall pooled estimate. So the relative risk was 0.74 with a confidence interval of 0.59 to 0.92 in this forest plot, showing decreased risk of severe ROP in the lower SAT groups. This is the summary meta-analysis of bronchopulmonary dysplasia, or BPD, in infants in low versus high oxygen saturation targets. Again, a relative risk exceeding 1 favors a high oxygen saturation target. So the relative risk here was 0.95, showing a decreased risk of BPD in the low SAT group. A relative risk of 1.25 here indicates a reduced risk of necrotizing enterocolitis or NEC in the higher saturation group. All 5 randomized controlled trials in this study were in concordance in showing an increased risk of mortality in the lower SAT group with a relative risk of 1.41 and favoring the high SAT groups for decreased mortality at discharge or at follow-up. There was no difference between the risk of IVH in the low versus high SAT group with a relative risk of 1.02. And there was no difference in the risk of PDA between both groups with a relative risk of 1.01. So, in summary, the NEOPROM meta-analysis found more deaths and more NEC in the low SAT group, 85 to 89%, while the higher oxygen saturation, 91 to 95% group, was associated with more ROP. There were no differences regarding physiologic BPD, brain injury, or PDA between the groups. Therefore, the NEOPROM group recommended that functional SpO2 should be targeted at 90 to 95% in infants with gestational ages less than 28 weeks until 36 weeks PMA till further studies are done. Well, I loved their summary of this meta-analysis in that they ended by acknowledging a few questions that were left unanswered by their study. So I thought I would try to attempt here to review and answer them. I thought it was really helpful and interesting that they did this. So the NEOPROM acknowledged that they did not have data regarding infants with gestational ages 28 weeks or higher who are also at risk for ROP. And true, I definitely agree with this. They reflected that it is unknown if oxygen saturation should be constant throughout the whole postnatal period, or should it be increased at a certain age. Here I disagree because we actually do know from both developmental physiology of the fetus and preterm infant supported by animal studies that ROP has a biphasic pathogenesis, so oxygen saturation ranges have to change when the infant matures. Next, they asked the question, should SpO2 targets be different for different gestational ages, and are there subgroups of babies who need different targets, for example, the growth retarded babies, or if the infant is infected? I do agree that this is not very clear. While the biphasic nature of ROP is an established fact, ROP can happen outside the box in sicker infants, infants with IGR, for example. So should they be screened for ROP? Yes. But where they fall on the biphasic saturation range spectrum is unclear, or if they are in a whole category of their own. The NEOPROM Collaborative then stated that, to date, we do not have any evidence-based data that may help us in answering these fundamental questions. I do disagree here. As a matter of fact, we do have the evidence, which has been largely, I guess, ignored or not accounted for over the decades when designing these clinical trials, unfortunately. Ideally, they also stated that the study concluded that these questions should be better answered by larger randomized controlled trials, and I do agree emphatically this is true. Yes, more better designed randomized controlled trials are needed to further guide the answers to these questions. This next couple slides is really more of the same. This is a recent meta-analysis of 4,900 infants in 2020 by the AAP that actually just differed from the NEOPROM Collaborative in that they added the stop-ROP data. So they had just about 47 babies more than the NEOPROM meta-analysis. The risk of severe ROP was significantly reduced in infants in the lower oxygen saturation group here compared to the higher oxygen saturation group, which was similar to the NEOPROM. The risk of death in this meta-analysis was observed to be significantly increased for the lower oxygen saturation group, 85 to 89%, compared with the higher saturation group, 91 to 95%. We note here that for the stop-ROP trial, the population of babies studied were bigger and older babies, and the intervention clearly differed from the other trials. For example, bevacizumab was not available at the stop-ROP trial at that time, so the relative risk for this meta-analysis could not be estimated with any accuracy. Also, the definition of death varied slightly as mentioned earlier in the NEOPROM meta-analysis. Well, these two clinical studies got it right, by actually increasing the oxygen saturation targets to mimic the increased oxygen delivery and oxygen consumption ratios that are similar to what's happening in fetal life. So these are two studies. So the first one is Olachi et al., a study from the University of Iowa from 2002 to 2012. Their oxygen saturation alarm limits were set at 3 age ranges, less than 26 weeks gestational age, 27 to 31 weeks, and more than 32 weeks. And then they also added two special categories of stage 2 ROP and being on more than 1 liter of oxygen flow, as well as infants that were getting high flow nasal cannula, mechanical ventilation, or nasal CPAP. So in the first epoch, which was 2002 to 2007, the oxygen saturation targets were not changed if the infants were diagnosed with pre-threshold ROP. In the second epoch, 2008 to 2012, in infants with stage 2 ROP and receiving low-flow nasal cannula oxygen, less than 1 liter per minute, oxygen saturation targets were increased to more than 94%, with alarm limits of 90 to 100%. For infants receiving high-flow nasal cannula that were mechanically ventilated or getting CPAP, the oxygen target range was more than 94%, and they set their alarm limits of 90 to 100% as long as the FiO2 did not exceed 50%. In both situations, the supplemental oxygen was not weaned below an effective oxygen level of 35 to 40% until ROP improved. So a significant decrease in the progression beyond stage 2 was noted during Epoch 2, with a graded SATs with 23% occurring compared with Epoch 1 that had 44%. The incidence of plus disease was decreased in Epoch 2 at 12% compared to Epoch 1 at 18%. So that was really encouraging. In this second study, Kayabyab et al., the incidence of ROP and severe ROP in extremely premature infants ranging from 24 to 27 weeks gestation were compared between two periods. In the first period, group 1, from 1995 to 2001, the oxygen saturation ranges were 90 to 94% from birth to about 35 weeks PMA, and they set it at greater than 94% starting at 36 weeks PMA. In the second group, 2003 to 2010, the O2 stats were graded at 83 to 89% from birth to 32 weeks PMA, 90 to 94% from 33 weeks to 35 weeks PMA, and greater than 94% at 36 weeks PMA. They found that there was no significant difference in mortality between the two groups. There was significant decrease in the incidence of severe ROP at 48% in group 1 versus 21% in group 2, and the need for laser treatment at 34% in group 1 versus 19% in group 2. Thus, the targeted grading of oxygen saturation was deemed superior in this study. So these two studies, I believe, are encouraging, showing when you allow that physiologic transition that happens by changing your oxygen saturation at about 4 to 6 weeks of life, you have better outcomes without mortality. So here are my proposed new saturation parameters for our group to consider. Below is a reminder in that box of our current oxygen saturation policy. I believe that simplicity is important for increased compliance, and you also don't want the two saturation targets to overlap, and you don't want a range that's too narrow to maintain or a range that's too broad that would pose a safety concern. So then the first group, I am proposing from birth to 4 weeks, if there's no supplemental oxygen being used, the babies be maintained at 88 to 100% SATs. It's okay to SAT 100% because they're not getting any supplemental oxygen. As long as the baby is getting any supplemental oxygen, the SAT growth should really change. We should tolerate 86 to 90% SAT range, and the alarm settings I propose to go to 82 for the lower SAT limit and 92 for the higher SAT limit. Then the second group would be babies from 4 weeks postmenstrual age, where we have increasing retinal hypoxia going on, and that hypoxic stimuli is now driving up increased VEGF secretion. You want at this point to reduce that hypoxic stimuli, and supplemental oxygen would be the therapy to use. So if there's no supplemental oxygen use from 4 weeks PMA, these babies are fine starting on their own 94 to 100%. But if for any reasons they're starting less than 94%, they need to be placed in supplemental oxygen. So the supplemental oxygen use group would have these SAT goals: a lower limit of 92% and a higher SAT range of 96%. The alarm settings would now change to a lower limit of 88% and a higher SAT limit for the alarm set at 98%. Here is a proposal for a special consideration for infants born at less than 40 weeks who are critically ill with IUGR, sepsis, have FiO2 needs more than 50%, and still less than 6 weeks postnatal life. They should be treated essentially like the birth to 4 weeks group. We should remember to check the effective FiO2 whenever we're using supplemental oxygen in this group using the Stop-Rub chart. You'd be surprised that the weight of the infant and the nasal cannula flow could very well be giving the infant close to 40 to 50% FiO2 or more, which puts them in the special category. Then, anyone with any pre-proliferative ROP stage 1 or higher, regardless of gestational age, will be moved up to a supplemental oxygen treatment group with a 2% increase in both min and max oxygen saturation targets and the alarm limits. So this is the special case consideration for our biphasic ROP guidelines. One should remember that pulse oximetry is really just an estimate of oxygen saturation. SpO2 measurements are a poor predictor of actual PaO2 levels, particularly when the infant is receiving supplemental oxygen. Remembering the oxygen dissociation curve, know that at less than 80% SATs there is an almost linear relationship between PaO2 and SpO2, but at more than 80% SATs, any changes that are small in O2 SAT cause large changes in PaO2. So essentially, I'm proposing here one guideline for everyone except babies with diagnosed ROP. Like any policy change, simplicity and ease increases adherence to changes and success. I hope the group considers this, and I'm grateful for all the wonderful care provided by the team for our premature babies. Thank you, and I'm happy to answer questions, comments, or address any concerns. Thank you very much.